Hello there, welcome to a special Plus Talk on Plus Life. A few weeks ago, I had the privilege of travelling to Kigali in Rwanda to attend IAS 2025. It is a big conference where science and HIV come together to discuss the very latest, and here's what we learned.
I think what this conference is going to do is also going to bring an appreciation of funding, that funding works hand in hand with science. So you can't discuss science without funding. You can't discuss science in terms of implementation of new technologies, scale-up of new technologies, discovery of new technologies, including vaccine, require funding, which has also been interrupted by funding cuts. So science and funding are going to work hand in hand in a case scenario that we've not witnessed before. Oh, I'm very excited about several pieces. One of the key things, we are going to hear about a new monthly pill for HIV prevention. This is a pill that could be taken for a month and reduce HIV infection. Research goes through phases. It has gone under phase 1, phase 2, which is showing promise. And now the science that's going to be presented is now opening doors for a large trial that's going to be conducted in sub-Saharan Africa and other countries, enrolling thousands of people. And these kind of big trials lead to policy change if it's shown to be safe and efficacious. So there's a lot of good science, and we are looking forward to a time when we are going to see the prevention toolbox looking like the contraception toolbox, where you have different methods to work for different populations at different times of their lifestyle. We have now newer tools, more effective tools, more safer tools. We have choice. For those who are not able to take pills can now go for injectables. For those who are not able to get injectables for women, when you have all these tools, we are doing well. And the data has shown that there has been a reduction in HIV incidence. So we're in a very good space, getting more tools, and now we just needed a final push.
Hearing new data, I think, is always, for me, the most interesting part of a conference. So hearing new data about new drugs, about new ways of using drugs, I find highly exciting. We're on the precipice of having long-acting treatments available for many, many people, but there are concerns around hepatitis B co-infection. How are these drugs going to be accessed by people globally? And just a lot of discussion about where these novel strategies are going to fit in a way that optimizes the lives of people with HIV the most.
We're super excited, like everybody else, around the promise of injectable, long-acting PrEP. We have set out the lenacapavir guidelines, which I think will start to address some of the countries that we have around the world, particularly in Africa and the continent of Africa, that have reached 95, where coverage is high, viral load suppression is high, but there's still people who are getting infected with HIV. Lenacapavir could be a game changer there, as well as with mother-to-child transmission. If we use lenacapavir during pregnancy for young women or women who may be at risk of HIV, again, important for the mom and for the infant. We're balancing the excitement of brand new science, as well as how do we maintain and mitigate the impacts on what we've had so far with the reduction of funding.
One of the difficulties we've had both in treatment and in prevention is that people have to take an oral pill mostly every day, and people struggle to do that. And so infrequently dosed options, and typically those are injectable depot type options, are really highly thought of for those individuals who are going to struggle with the daily pill. And we have them both for treatment now and for prevention, and that's very exciting. So it's about choice, and it means people are more likely to have coverage of their risky behaviors or their potential exposures, and that means better prevention. And for those people who struggle on the treatment side, it means that they're more likely to be virally suppressed and thrive on their treatment. It is, in a way, incredible because we've never seen that kind of result, especially amongst adolescent girls and young women in Africa. So I think it just shows that this is something people can really identify and use. It's been described as a game changer. I certainly hope it is going to be that game changer. We have 570 infections in young women and girls every single day in this region. We have to do something about that. And I believe that long-acting Len for PrEP could be that game changer. We cannot lose ground. We have to find a way forward. And that's going to take ingenuity. It's going to be digging deep, making sure we're making the most of local, holding our governments to account, because that is where a lot of the funding has to come from, and making sure that we we just resolve, we will not go back. But I do think we are now going to have to say, we have to rise above this. We have to dig deep, find ways to overcome initially this acute catastrophe, get to the other side, and then recalibrate, keeping the 2030 goals in our minds. And there are some serious mile markers along the way. We've got to find those 9.2 million that still are out there and have not benefited from our care and treatment. Cannot renege on primary prevention. There is a real risk that people will say, in order to save money, let's just concentrate on treatment. And that would be a huge mistake. So what do we do to say we've got to bring these along? And I think it's going to need novel funding mechanisms. It's going to need the rest of the international donor world to say, well, maybe the responsibility now falls to us. And I continue to hope that humanity will prevail, even in the all-powerful United States of America.
From game-changing science to the communities it's meant to serve, because progress only counts if everyone's invited in.
IAS 2025 is important because it's the scientific conference. For people living with HIV, the science has kept us alive. The science works every day to find better ways to provide treatment, better ways to prevent new infections, optimized ways of ensuring our treatment works better for us and causes less damage to our bodies. So sitting in a scientific conference is an opportunity to understand what's the progress in science, what opportunities are upcoming, where can communities and people living with HIV participate, be it in research studies or in shaping up plans for research and scientific options. I've been to a couple of IAS scientific conferences before. This is the first one I've seen the most community presence. So if there's one way of confronting stigma, it would just to be making sure that people who are really affected by the stigma are in the conference. So there's a little bit more of people living with HIV, people from the LGBTQ community, people from key population community in this conference. Scientific conferences like this provide an opportunity from which social aspects and the actual medical aspects of the science come together to provide guidance for policy. Then it makes sure that services that we receive as people, both for HIV treatment and prevention, are conscious to the needs of the people.
I am very, very big on amplifying the voices of community, and I think the resounding message that at the heart of everything, communities are very important. In science, science needs communities to find results that advance, opportunities, but also communities are the ones that have the stories and have the experience, and that's very important for us to be able to have the platform to share who we are and what our needs and our challenges are, to be able to better advance the work that we're doing in the HIV response. Also, it's a great opportunity to talk about science, and I think science brings hope to the communities that we serve. It allows us to, in many ways where people are not aware of will I live longer, for instance, or how can I have a better quality of life? So the research that is getting presented here allows us to bring that message back home. And it's very good to hear that there are people that are passionate about the work that they're doing and contribute to a change in our spaces. We had research presented at this panel where there's being able to find, what are some innovative ideas and innovative lab technology that we're able to take one pill a day and then soon they might be able to have an injection every 6 months. I think that is so hopeful because we have to admit at the end of it, there's people that are taking this treatment and we have to be very people-centered in our approach.
We are saying that communities are experts and that communities, you don't have to have a PhD or run a randomized control trial in order to be able to bring data or influence to the table, that communities bring lived experience, they bring their own expertise in specific areas and should be valued and should have space on the table to influence decisions. And I think what we really need to realize is that the system is super fragile. Governments can change their minds, donors can change their minds, and then our whole response to a global health threat has collapsed. And so we need to build a system that's much more resilient and more responsive to the majority world, to what people who are affected by a particular disease or issue in general can say, this really works for me. HIV is part of global health. and global health is sort of falling off of the political agenda, and we need to make sure that we build a system. We take this opportunity, don't waste the crisis that we're seeing in front of us now. And so communities are adapting, communities are responding, governments are doing the same, they are finding the funds within their fiscal space, but it's not easy. And so we have to think outside of the box. We have to understand what philanthropy can do, what industry can do. Communities are paying attention, they have data that they can bring to the table, and then this data can then turn into insights which can bring solutions. So community-led monitoring is an example of what communities do regardless. Community insights can remove the blind spots from the health system and really show you what people on the ground are facing.
I think it's now standard that people with and affected by HIV are central to the programme development, to the programme chairing, to delivering talks. And I just think, even just in the last few years, that's now become so ingrained that it would be just abhorrent to not have that. So I think that's a really important thing. The theme that has been quite dominant for me here is this issue about people who are living with HIV and hepatitis B, or who have had hepatitis B in the past. And hepatitis B reactivation or new hepatitis B acquisition in clinical trials using antiretrovirals that aren't Hep B active, I think is a really important dilemma for the pipeline of HIV treatment. And I think that message, vaccinate. We've got vaccines that work. Nobody should be entering a Hep B inactive clinical trial who hasn't been vaccinated.
Well, I think countries have been making excellent progress in testing and treatment, especially in this continent, and viral load suppression. But there are other parts of the world where we have to turn up the volume on actual testing. So self-testing is going to be important there. We see parts of the world where there's increasing new infections. That shouldn't be happening anywhere in the world. So it's testing, treatment, prevention being brought forward, PrEP being brought forward.
We spoke about aging, and nice to see some focus on positive aspects of aging and how to make sure people age well.
But I think also ensuring that as people age, they get the other services they need, whether it's diabetes care, hypertension care, integration into mental health, because that's where we're going to be going as we go further into the, 40 plus years of this epidemic.
There are a lot of women at this conference. Women Know What Works was a pre-conference yesterday. Breastfeeding. Where are we at with sort of the U equals U message of that undetectable equals untransmittable being applied to breastfeeding and a clear guidance so women can make a choice?
Yeah, I think it's a really important question, and we've been asked this many times. So this year we took on the systematic reviews. We had a guideline group and a group of experts taking a look at exactly this question, because we've already recommended breastfeeding for women who are living with HIV is best because it's good for the infant, it's good for the mother, etc. But we know there are parts of the world where women are not allowed to or offered breastfeeding. So we looked at it in that context. What are the other settings, whether they're high income, middle income settings where breastfeeding may not be offered? Because of the considered minimal risk of transmission to the infant. And what the systematic review and the guideline group came up with is we are offering for at any location, any setting, that women should be offered breastfeeding. And the conditions to be offered breastfeeding are just like what you say: having a viral load that's suppressed, having an infant who has access to the postnatal prophylaxis. Then the risk of transmission is negligible, very similar to what we put out last time in our viral load document for heterosexual or any sexual transmission. So I think we're getting there. I think the goal here is, as medicines get better for women and for infants, and as viral load suppression is maintained during pregnancy and during breastfeeding, the risk of transmission is negligible.
And I think the critical thing is choice. We hear this all the time. There's some great data from contraception showing that the number of contraceptive choices correlate beautifully with the proportion of people using contraception. And the same seems to be true for PrEP. And where people have a choice, coverage is better. And we're not going to be able to treat our way out of this. We need good prevention options also. The more we have, the more choice people have, and that choice may change over time, is absolutely essential. So we had a brilliant conversation about weight. Looked at the data that is all fairly familiar, but really some great discussions about cultural attitudes towards weight change, and actually in many cultures being bigger is a sign of health, a sign of wealth. But we also spoke about the fact that although we see great results for the new drugs, the GLP-1 agonists and the like, in terms of reducing weight and improving outcomes for people, whether they have HIV or not, the difficulty is those drugs aren't going to be affordable for so many, and ultimately obesity is a social and a political problem, and we need to find social and political solutions.
AI is popping up everywhere, especially in vaccine research. What role do you see it playing for HIV vaccine development?
The role of AI is so much promise, and so much promise in vaccine research. Like with everything that you could apply AI to, it makes it better, it makes it faster than any human expert can do, and it can make your cost reduce because you're now doing things faster and better. We need to solve for lives and lived experience. We want to make sure that we put that tool in the hands and we use it ethically, and we want to make sure it doesn't continue to exacerbate the inequity that we already see. AI is a tool that's put into the hands of communities in particular, not just scientists and researchers, so that they can also use that tool for their power. I think it is exciting, and communities are already using that. We use CLM, we already use AI to make our analysis faster and to do our uptake of data. The argument is that AI can free up resources for those vulnerable communities and within the health system itself if you use it effectively. There is no science without communities. I think that is really the critical point. No one is coming to save us, and communities will continue to step up whether or not there's funding or not. But if you continue to not invest in communities, that's called extraction, and that's not really investing in community systems. I really want to say that communities are experts, and let's continue to invest in communities. That is the sustainable response.
Tech might be transforming the how, but the real question is, what's next? Where do we go from here?
I think one of the key things is to advocate for the science. I want people in the global HIV community to appreciate the role of the science. I want the people to access and also build capacity beyond the senior scientists like ourselves to junior scientists, so they're able to come into these kind of conferences, and I encourage them to come because this is the places where they first of all see the breaking science, they network with colleagues, and they're able to anticipate and plan better. We have a vision to also ensure that communities are also able to access the conferences as much as possible. We are going to continue working with policymakers, we are going to continue working with communities, we are going to continue working with scientists, all stakeholders, including yourselves, the media, to ensure that we have a harmonized approach towards ending HIV pandemic.
We still don't have a cure, we don't have a vaccine, but we're every day slightly closer to getting to those points, because in 40 years we've learned so much about this virus. And here I want to call out, this research has been an incredible partnership between universities, institutions, funding agencies in the north, and organizations, researchers, communities who've stepped up in the global south. And those partnerships have moved the science forward in the most wonderful way. And we have to hold on to that, and again, absolutely resolve that we will not give up on the science. The science is straight and true and will take us collectively to the end of this epidemic.
It's very important for us not just to use people, but meaningfully involve them in how do we use their voices in improving our approach, but also how do we partner with communities for us to be able to amplify the work that we do.
Can you imagine if we work with young people to design HIV prevention, HIV treatment, HIV testing campaigns that go viral in hours? We would make steps. Let's engage people living with AIDS. They know how best to communicate to their community members, as opposed to a person like me seated behind a desk and designing communication messages or communicating.
We have tools, we have ideas, we have resilience. We have to go forward, whether it's that individual in terms of their life, this is the beginning of the rest of their lives and they can thrive, or whether it's the community as a whole. We have to go forward. I've got my eyes on the 2030 goal of bringing this epidemic under control as a public health threat, and I am not going to deter from that.
It really was a privilege for us at Plus Life to be on the ground there at the conference. Hey, that's going to do it for this special Plus Talk. Remember, you can like, follow and share. We're across all your favourite social platforms at Plus Life Media. The website is pluslifemedia.com. Until next time, be nice to one another. We'll see you soon. Bye-bye.